Everyone's here. Okay. All right. So, like I said, tonight will be quick, short, and hopefully pretty straightforward. So we're talking about digestive system and GI disorders. Come on now, work with me. All right. So, anatomy and physiology of the GI system. We have our canal organs, which, make up. Hold on, let me get away from my dishwasher. That probably is loud. The canal organs make up basically the canal that carries the food on through. So you got your mouth, you got your esophagus, stomach, small intestine, and large intestines. Okay. Food obviously is broken down first in the mouth with your teeth and your saliva, and then it travels on down the esophagus and through the lower esophageal sphincter into the stomach, where it is further broken down and then passes on through the duodenum and then the jejunum and the ileum on through the small intestine and then around to the large intestine and out. So we will go through this piece by piece, talking about the canal organs and then also the accessory organs. The accessory organs make and secrete enzymes or chemicals that also aid in the breakdown of food and absorption of nutrients. So tonight we're going to talk about upper GI stuff. So that will include the esophagus and the stomach. Obviously, the heart supplies oxygenated blood to the GI tract, just like every other part of the body, except the only difference is in the intestines, the blood is then transported to the liver, where more nutrients can be absorbed and then transferred to the heart. And that is through the portal vein system. That will be important next week when we talk about the liver. I'm not going to talk about esophageal varices tonight, but we will cover that next week as well when we talk about the liver. The gallbladder, the pancreas, those organs, they all make those enzymes, like I said, that help break down the food. Now, let's start with the esophagus, okay? It's a muscular tube. It starts right there at the back of your throat, or your pharynx. It lies behind your trachea or your windpipe. You know, when people say, oh my God, it went down the wrong pipe. Yeah, because your food travels to the back and it can either go down your trachea or your esophagus, right? The lining of the esophagus, it is mucosal lining. So just like your mucous membranes, your mouth, your vaginal area, for lack of a better idea, but it's a mucous membrane. The mucus is secreted to aid in lubricating food as it slides down the esophagus. The muscularis tissue, okay, the muscular tissue in the esophagus aids in digestion in that it constricts and relaxes and pushes the food on down the canal, right? That movement is called peristalsis. So certain medications may slow down peristalsis. When we talk about nervous system and we talk about fight or flight versus rest and digest, certain things peristalsis is going to stop or slow down, while certain action of certain nervous system will have your peristalsis speed up. Okay. But we'll talk more about that with the nervous system. Right now, we're just talking about GI. All right. So everyone sees that. Now, talking about esophageal disorders. So, first of all, let's start from the beginning, the mouth. Anyone who has issues with their dentition, their teeth, they are missing teeth, they have poor, they have a lot of teeth decay and pain, dental caries. These people you're always going to need to consider nutrition and diet for them, because if they have difficulty chewing or pain with chewing or anything like that, then it is going to obviously disrupt their diet and their nutrition. While dysphagia is not in your books, I'm just trying to tie everything together. It will come up again when we talk about nervous system. But dysphagia is a medical term meaning difficulty swallowing. Sometimes it is also used as painful swallowing, like when someone has a sore throat, but more commonly used for difficulty swallowing. Possible causes could be damage to your central nervous system, including cranial nerves 9 and 10. Talk about that again with the nervous system. A narrowing in your esophagus or a lack of salivary secretion. If your mouth is dry or if the food is dry, aren't you going to choke on it? Muscular weakness, like you see with cerebral palsy and other musculoskeletal disorders, or anything that causes muscular weakness. Symptoms of dysphagia would be choking, gagging, coughing, or a gurgling voice, like they sound like they have water gurgling in their throat when they talk. So another esophageal disorder is GERD. As far as the PEDS book goes, it describes gastric. Now, some people can just have acid reflux, gastroesophageal reflux. It becomes a disease when it's chronic and it's causing, irritation, chronic irritation to the esophagus. For example, you could get heartburn once and then never get it again for whatever reason. Maybe, I don't know, maybe that day you were gassy or something was going on, your clothes were too tight, you ate too much, and you had heartburn that one time. That doesn't necessarily mean you have GERD, okay? So when you look at the PEDS book, it talks about GER and GERD. GER is just like, okay, you get some heartburn, but it's not a chronic disorder. And for babies, that is common for newborns and typically resolves within the first weeks of life. If it persists, then it's considered GERD. What's happening with GERD is the gastric contents, gastric or gastro always refers to stomach. So the stomach contents and enzymes, AKA the stomach acid, is backflowing into the esophagus, leading to irritation and can even cause ulceration of the esophagus, which would then be a peptic ulcer, right? So GERD, it can be self-limiting or it can be debilitating, okay? Causes are an incompetent lower esophageal sphincter. Now, colic. Okay, colic is a general, Vanessa's asking, would that be what they call a colic baby? Yeah, they believe, yes, colic babies who are colicky could be what's going on with them. They're having GERD. Colic is like, they use that term, so it's kind of a, what do I say, like a layman's term, because people use that for babies who are crying a lot or whatever, but colic really, they have to be crying for an extensive period of time, consistently. And a lot of times they have thought that it's probably related to GERD. So yes, that's right, Vanessa. Causes could be, uh-oh. Yep, it's terrible. My son had colic. It was horrible. Like 3 months straight, crying majority of the day, nonstop. I was like, I don't know if I could do this. Yeah, it's terrible. Incompetent lower esophageal sphincter. So as you can see in this close-up picture over here, the LES in closed position. The LES is a sphincter, lower esophageal sphincter. A sphincter is like a valve, okay? This valve opens and closes to allow food to pass, but it's supposed to be a one-way street, okay? So food should always come down the esophagus and into the stomach. It should not back up through the sphincter, the lower esophageal sphincter. That sphincter opens and closes due to muscles contracting and relaxing. So as you could see in that close-up picture, the little circle right here, it is just that muscle is contracted and the sphincter is closed. If those muscles are too relaxed, then the sphincter will open. Okay. So an incompetent lower esophageal sphincter, for whatever reason, whether it's muscular weakness or whatever, will cause food to back up. Pyloric stenosis, we'll talk about that in a minute, will also cause food to back up. And when we talk about pyloric stenosis, you'll understand why. Same with hiatal hernia. We'll talk about that in a minute. Excessive intra-abdominal or intragastric pressure, meaning pressure inside the stomach or around the stomach, just in the abdominal cavity. So that could be a pregnant woman. Your stomach's all pushed up all the way up into your chest to make room for your baby. It could be an obese person with a big belly and a lot of belly fat. It could be you ate too much, like you went to Old Country Buffet or whatever, and you just stuffed yourself for whatever reason. You just failed your first exam and you needed to stuff yourself. Now, the lower sphincter, lower esophageal sphincter can't even stay closed and stuff's just backing up. Or there could also be motility issues. Again, an issue with peristalsis, whether it's muscular weakness, atrophy, something like that. Risk factors, obesity, like I said, is going to increase intra-abdominal pressure. Older age, with older age, you know, everything slows down, muscles relax, they get atrophied. So you may end up, you may be at higher risk for a incompetent LES, sleep apnea, and pretty much asthma and any other COPD, any respiratory disorder, because of the way the trachea and esophagus are right next to each other, and you're having bronchotracheal spasms and stuff like that with those respiratory disorders, they often have issues with GERD. NG tube, obviously when you put an NG tube in, and we'll talk about those next week when we talk about bowel obstructions, but it's going in the nasal cavity, down the passing the pharynx and into the esophagus and down to the tip. The tip should be in the stomach. So it's going to what? Open up the LES. It's going to leave it open. Also, certain foods, fatty, fried, and acidic foods are going to put you at risk. Chocolate, other foods, we'll talk about the foods on the next slide. Smoking irritates your throat, the coughing and all that, again, going to put you at risk. Just smoking just puts you at risk for everything, okay? Just remember that. Pregnancy, like I said, going to increase intra-abdominal pressure. Coffee, yep, coffee, caffeine, certain medications, premature birth, asthma, cerebral palsy. The list goes on, and it's in your ATI book. So again, you have to read. You can't get everything from the slides. So read your book. There's that. Moving right along. Maybe. What's going on here? All right. Somebody have a question? No? All right. GERD. So, clinical manifestations, meaning signs and symptoms, what the patient's going to describe and what you're going to see. They're going to complain of indigestion, aka heartburn. They're going to have this chest pain. I'm sorry. More often than not, GERD and acid reflux or gastroesophageal reflux sends patients to the ER thinking they are having a heart attack, okay? Because they have this pain, this horrible pain in the center of their chest. It's tightness, and it may radiate to the back, the neck, or the jaw. They may have pain on swallowing. They may have excessive belching because of that incompetent LES. They may have pain that occurs after eating. That pain that occurs after eating is what causes babies to refuse to eat, and they end up with failure to thrive. Pain may be relieved immediately with drinking water, sitting upright, repositioning, or antacids. Like, think about it, when you lift heavy stuff, when you bend over like all the way, it increases the intra-abdominal pressure again and could cause acid reflux or GERD. So if you're doing a job where that's all you do all day is lift, 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 that is going to put you at risk for GERD. Chest congestion and wheezing may occur due to aspiration. Again, the esophagus is right there, right next to the trachea, right behind the trachea. So it's not hard for them to aspirate on some of this reflux stuff. Diagnostic procedures are going to include the EGD and esophageal pH monitoring, which I've never seen done. These are things that will probably be done in the EGD lab, in the endoscopy lab, sorry. And a barium swallow study is just a radiographic exam, like a CAT scan, while they drink this dye, okay? As for the pediatric considerations, so this is where that cross lifespan stuff occurs. Symptoms in infants may be different, obviously, because they're not going to be able to tell you they have heartburn. They may have spitting up or forceful vomiting. They got that colic, like Vanessa said, irritability, excessive crying. You may see blood tinge in the vomit. I'm not talking about blood clots and you're vomiting up blood. I'm talking about blood tinge in the vomit. And I'll show you examples just to be as specific as possible in just a second. There may be arching of the back because remember, it's like that burning in the center of their chest and it's going to the back, radiating to the back. They may be stiff. They may have respiratory problems if they've had aspiration. And again, like I told you, that failure to thrive. And apnea again, respiration problems or respiratory problems because of the aspiration. Older children, they're going to have the same complaints as adults, basically pain with swallowing, not wanting to swallow. They may have a chronic cough, and adults may have that too if they're having chronic GERD. Okay, so EGD, what is that? It is an esophago-gastroduodenoscopy. That is, they're going in with an endoscope. Endoscopy is use of that endoscope, a flexible lighted camera that is used in many procedures to look at different organs inside the abdominal cavity, all over, okay? So endoscopy You use endoscopy when you do an upper GI study or EGD. You use endoscopy when you do a lower GI study or colonoscopy. Okay. So with the EGD, they're looking for bleeding. They may want to dilate an esophageal stricture or narrowing. So like a stricture or narrowing would cause what? What? What might a stricture cause? How about dysphagia? It's going to be difficulty swallowing if the canal is narrowed. A stricture is like a tightening or scarring. It can also be used to go in the stomach, find ulcers and things like that. And I'm actually going to show you an EGD in a minute. The procedure requires moderate sedation. It's going to be hard to go down into somebody's stomach with a camera without some level of sedation. It's not general anesthesia, but it is moderate sedation, and that usually entails some sort of benzodiazepine, usually diazepam, which is Valium, or midazolam, which is Versed, and it may include fentanyl, which is a pain medication also used to relax them. Yeah. Positioning, they're going to be positioned on their left side for the procedure. Preparation, they're going to be NPO 6 to 8 hours prior to the procedure. So if you have a patient in the hospital and they're going for upper GI, because these are used interchangeably. Your doctor may tell you they need an upper GI, they may tell you need an EGD, same procedure. So if you have a patient, they're scheduled, they need to be usually NPO after midnight. Look, I'm not going to be able to see nothing with my camera if this is the day after, you know, you just had breakfast at the Old Country Buffet again. Well, I'm just going to be seeing a bunch of food debris. So NPO. After the procedure, you need to monitor their vital signs, monitor respiratory status, because you just gave them all that moderate sedation. Moderate sedation is the same as conscious sedation. You may have heard that term before. Same thing. You're going to maintain NPO status. So again, because you gave them these drugs, they may be so relaxed that they have no gag reflex. This can happen with severe alcohol intoxication. People can have no gag reflex. And have you ever heard of Jimi Hendrix? That's how he died. He aspirated on his own vomit because he was so intoxicated. It can happen. So these drugs can have you so relaxed. You can aspirate because you have no gag reflex. So make sure they're NPO until the gag reflex returns. Then you probably start with clear liquids in advance as tolerated. They cannot drive. They need to get picked up. You just gave them all that medicine. They cannot drive or operate machinery. And then if they complain of a sore throat, this is common, or they may have a little laryngitis because you just shoved a big old camera down their throat, okay? So you can give them throat lozenges. As far as patient education, all these foods over here, things to avoid, ketchup, you know, tomatoes, those things are acidic. Any citrus fruits, even though those aren't over here, but lime, lemon, we know those are acidic. Caffeine, alcohol, all that. And you read more in your book. Again, I cannot emphasize enough the importance of reading. But I promise you, the basics and the topics will always be covered in lecture. So you want to teach these people about obesity. They need to maintain a healthy weight, exercise, diet, whatever. They don't want to be obese because that's going to increase intra-abdominal pressure and force food back up the lower esophageal sphincter. Quit smoking. You should always quit smoking. There's no reason to smoke. Don't smoke, period. It's 2021. If you don't know that by now, you may never, ever know, okay? Stop smoking. Avoid alcohol or limit your alcohol intake because alcohol irritates the esophagus. I mean, smell it. You know, alcohol is an irritant. Um, the reason alcohol irritates the esophagus is that it, we'll talk about it in a minute, but it wears down the lipid protective layer of these cells. So it is an irritant. Avoid alcohol if you have GERD. Avoid acidic foods, spicy foods, common sense. Avoid foods that lower LES pressure. So that will be caffeine, fatty and fried foods, chocolate. Avoid eating before you lay down, period. Laying down, obviously, if I eat and lay down, I'm going to have probably some heartburn, even if I don't have GERD. Same with babies. That's another reason not to prop a bottle up in your baby's mouth in the crib while they're laying flat. Going to be more likely to have acid reflux. So you want to position the baby, you know, upright when you're feeding them. Avoid tight fitting clothes. You know, I mean, maybe you need to loosen it up. Don't go to Old Country Buffet. That's why people need to loosen up their belt, make room. Stop wearing that super tight stuff if you are having chronic acid reflux. Elevate the head of the bed for patients in the hospital, or for patients at home. I mean, you could prop yourself up on pillows. Avoid lifting heavy objects. And again, babies, when it's time to lay down, lay them in the supine position rather than prone. And older infants, once they are able to roll over, you can lay them on their side or sitting upright like in a boppy pillow. GERD treatment. You have your PPIs. Now, you already took pharmacology. This is not a pharmacology class. However, as we go through and talk about disease processes, your pharm is going to come back up. So everything, like I said, should be building on the previous subject, previous classes. You know, immunity and inflammation is certainly going to come up again. So your PPIs are your prazoles, your omeprazole. I put omeprazole on there twice. I'm sorry. Omeprazole, pantoprazole, esomeprazole, lansoprazole. That's Prevacid, Prilosec, Protonix. Yeah. But anyway, prazoles. The way they work is they inhibit the cellular pump of the gastric parietal cells needed for gastric acid secretion. The thing about PPIs is the work that they do is somewhat irreversible, so they are not meant for long-term use. Long-term use increases risk of fractures, especially in older adults. So we don't like to use them unless absolutely, like, again, remember, everything in medicine is all about risk versus benefit. So are you never going to see an elder adult on Protonix or Prilosec? No, you probably will see them. But I guarantee, and I can tell you as a prescriber, Walgreens, CVS, the pharmacist will be sending you material letting you know you shouldn't be giving these older adults those meds because it puts them at higher risk for fractures. It also, because of the irreversible decrease in gastric acid secretion, it puts people at higher risk for pneumonia and C. diff. Because again, that acid, it breaks down your food. It also, these enzymes and acids also play a part in, you know, killing bacteria. You think, look at all the food you eat. You should have caught probably 1 million diseases. The places you bought food from, the restaurants, everybody knows some hole in the wall, rink-a-dink spot, some random fast food spot that you can't help but love it, but you know they're nasty. And yet you don't get diarrhea every time you eat there. You don't get, you know, E. coli infection. That's because you have your normal flora And you have other enzymes in your body that help break stuff down. So here comes that opportunistic infection, C. diff, with the excessive use of PPIs. So while PPIs are great, don't get me wrong, they work wonders, especially for the acute attack. They shouldn't be used long term. H2 receptor antagonists or H2 blockers. Remember when we talked about inflammation, histamine. Histamine secretion also increases gastric acid secretion. So when histamine is secreted, when it's secreted, the H2 blockers are going to block the work of the H2 receptor antagonist. I spelled antagonist wrong. Antagonist. H2 receptor antagonist. They're going to block what histamine does to the stomach. They're going to block that secretion of acid by blocking the work of histamine. While the onset of these drugs is longer than antacids, which we'll talk about next, the effect has a longer duration. However, PPIs last even longer. PPIs are usually only taken once per day. H2 blockers are usually taken twice per day in separate doses. You take them usually with meal and at bedtime. So usually in the morning with breakfast and at bedtime. Proton pump inhibitors you usually take prior to your first meal of the day. Because of the way the H2 receptor antagonists work and the way they are filtered, you want to use caution when treating patients with kidney disease. Antacids. Those are like your over-the-counters, your magnesium hydroxide, which is milk of mag, your calcium carbonate, which is Tums, sodium bicarb, okay? We will talk more about acid base in a couple weeks, but antacids work as a buffer. They neutralize excess acid and they increase the pressure of the LES. So keeping those gastric contents where they're supposed to be and neutralizing the acid. We'll talk more about levothyroxine later, but ensure contraindications such as being on levothyroxine, also kidney failure when using anything with magnesium. Kidneys are the only way magnesium is excreted out of the body. So if you have kidney failure, you do not want to be giving these. You want to be very cautious in giving these people excess magnesium because they're not going to be able to excrete it. And we'll talk about more of this later, but magnesium plays a part in your cardiac rhythm. So you don't want to load these kidney people up excess magnesium. Antacids are going to be taken on an empty stomach, basically, or after eating. You want to take them when acid secretion is the highest, so after eating and at bedtime. And you don't want to take them with other meds. The last medication, which is rarely used for GERD, but it is used and it will come up again, is metoclopramide or Reglan. It is used sometimes with other situations, but rarely, but sometimes I guess it could be used for GERD. That's probably more of it depends on the issue why you're having the reflux. It will probably have to do with motility, peristalsis, the movement, okay, of the muscles. Otherwise, if that's not the cause of your GERD, you're probably not going to get Reglan for that. The only thing I want you to know about Reglan, you may even see commercials about Reglan because there have been class action suits about Reglan. Also, one of the H2 blockers, ranitidine. It's in your ATI books. However, over the last year, ranitidine was pulled off the market. So because the books are behind the times, I'm not sure if ranitidine will be on NCLEX. I would hope not, because it's no longer on the market at all, because it was linked to causing cancer. So, but it is in your ATI books, and it's with the famotidine and everything else. Yep, GERD, causing cancer. Yeah. So hopefully it may come up on your ATI proctor exams, just because ATI, these books are from 2019, and that just became an issue in 2020. So hopefully it's not on NCLEX. So, but that's just a side note. And Reglan, again, but Reglan is on the market. Reglan is in use. Okay, so you do need to know about Reglan. It is in this chapter, but we'll talk about Reglan even more so with diabetes, because it's more commonly used for diabetic gastroparesis. The thing about Reglan is it can cause extrapyramidal symptoms, EPS. I threw this in here because it does go with mental health. It is big in mental health. It is a common side effect with antipsychotic medications, but it is also a adverse effect of Reglan. So that will be the biggest, that may come up on your exams at some point. So extrapyramidal symptoms, there's different ones. There's tardive kinesia, there's akathisia, all this stuff. But on the next slide, I'm not going to show you this, but I just put it in here just to help you guys with mental health, because I know this will come up. There are 2 videos here with the links to the videos as well. We're not going to watch them right now, but these are videos, really excellent examples of EPS. You may even be able to recognize people with EPS if you work in a nursing home, or if you're somewhere even in public. You may be able to recognize people in the future, like, okay, that person might have schizophrenia or something, because they look like they're on antipsychotics, because a lot of people with antipsychotics have those same EPS. May not pertain to GI, but again, I want you guys to be the most well-informed nurses, and do well in all aspects of school and nursing, without giving you too much nonsensical information. All right, GERD, last thing, potential serious complications. Aspiration is always, aspiration. We talk about ABCs, airway, breathing, circulation. If I aspirate on my gastric contents, then what's going to happen? I could choke and die. I could get aspiration pneumonia. I don't want that. Okay. That's why, when people are on tube feedings, we don't lay them flat. We don't want people laying down flat eating. We don't lay babies propped up with bottles in their mouths. And anybody who has, because all those things are going to put you at risk for reflux and put you at risk for aspiration. Let's see. This can lead to asthma exacerbation, because now you have this aerosolized acid. Remember how close the airway is, right next to the esophagus. And thus it can cause frequent upper respiratory infections, so sinuses, ear infections. It can also cause aspiration pneumonia. Talked about that already. Now, we will talk about cancer later in the semester, but what you really need to know, one of the main risks of cancer is chronic irritation and inflammation. Does that mean every single person that gets cancer had chronic irritation or inflammation? No, but you're definitely going to put yourself at significant risk for cancer anytime you have chronic irritation or inflammation. So with GERD, chronic inflammation of the esophagus is going to lead to Barrett's epithelium. Barrett's epithelium is basically like precancerous cells, pre-malignant appearance. In this picture, here's like a pre-malignant Barrett's esophagus, okay? It's not pink and moist and pretty. It looks all eroded and irritated. That can easily evolve into cancer or esophageal adenocarcinoma. It also can affect, put you at risk for oropharyngeal cancer and cancer of the trachea and larynx, because they're all right by each other. That acid is going to irritate everything. And in the babies, it's going to lead them to have failure to thrive and weight loss. They're not going to want to eat because it's burning. Or in those nonverbal, brain, traumatic brain injury or stroke or elderly dementia patients, same thing. Failure to thrive and weight loss may be a result of GERD. Does anybody have any questions about GERD thus far? All right. Moving on. Hiatal hernia. The reason I'm telling you about hiatal hernias is because it is just another thing that will put you at risk for gastroesophageal reflux. It will increase intra-abdominal pressure. It will cause stricture of the esophagus, all these things. Yeah, it will, the treatment and everything else is going to be the same as GERD, besides if you need a surgery. So a hiatal hernia is basically, you see this picture here, the diaphragm muscle is above the stomach. The diaphragm, if you remember from A&P, it flexes or contracts and releases to aid in your respirations, right? And it lays above the stomach here. Through there comes the esophagus. However, if there is a weakness in the diaphragm due to maybe your diaphragm's been overworked from respiratory disorders like COPD and asthma, or if you're obese, things like that can cause a weakening in that diaphragm muscle. So because of that weakening, now part of the stomach is able to push through that opening called the hiatus, hence the hiatal hernia. So part of the stomach is going to protrude through. The way it protrudes through will tell you whether it's a sliding, which is the picture in the middle, or whether it's a paraesophageal, which is the picture on the right. Para meaning around or near, and esophageal. So para, it's on the outside near the esophagus. Pulled this information straight out of ATI. Again, can't express how important it is to read. So, treatment. Education, lifestyle modifications, all that, same as GERD, okay? Not every single person with a hiatal hernia is going to require surgery. Diagnostic procedures, pretty much the same as GERD, except a CT of the chest. CT of the chest can identify that hernia, okay? The treatment, again, lifestyle modifications, same as GERD. And then the surgery that a patient could possibly get, if this is just too unbearable, it's causing way too many symptoms, because remember, surgery is usually the last ditch effort, last case resort or whatever. Unless it's no other choice but surgery, like with appendicitis. But anyway, for this one, it's a last ditch effort if the patient's just having recurrent symptoms and is causing, decrease in their quality of life. The name of the surgery is a fundoplication. They could do it open, or they could do it, making small incisions with a camera and laparoscopically. Only thing about that is after the procedure, this care you're going to provide them is basically the same no matter what. And you see the way that they do this surgery is basically they're just adhering the stomach in some way, either around the esophagus tightly or to the esophagus to keep it from sliding up and down or pushing through, keep it stabilized, okay? But the care afterwards is the same with pretty much any GI surgery. Elevate the head of bed. HOB is head of bed. Elevate head of bed to help them expand their lungs. You're going to teach them about deep breathing and coughing to prevent pneumonia, which is a common complication after abdominal surgery. You're going to teach them to support the incision, meaning like brace a pillow or something like that during movement. That will help with the pain. Like when they need to cough and deep breathe, they may need to hug a pillow. When you have lower GI surgeries, you may need to hug a pillow when you have a bowel movement because it hurts like heck. Soft diet for the first week following surgery. Again, that's probably with most GI surgeries. And then you're going to avoid carbonated beverages and avoid heavy lifting. Likely, fundoplication is not going to be on your exam or NCLEX, but I'm trying to tie everything together. We will talk more about surgery and perioperative care later. But I just want you to know you're going to see patients with hiatal hernias all the time in your practice on the floor. So you need to know what it is, and you need to know that it increases that risk for GERD. So far, everybody good on esophageal disorders and how this is going? The reason I think exam 2 is going to be so much easier, 1, we're only talking about one system. 2, for most of these disorders, the treatment is exactly the same for the most part. Okay? So when we go system by system, it'll be much easier than this first exam.
Hey, Professor, I got a quick question. Sorry to cut you off.
Go.
When those patients get that surgery for like when they're super obese and they want to like have that abdomen or the stomach surgery to cut back on the amount of food they eat, are they at higher risk for this hernia, or does that have nothing to do with this?
That's a good question. Actually, to be honest, I'm not gonna sit here and make stuff up. You would think it might put you at risk. But well, I'm thinking it might put you at risk for acid reflux because you're basically making the stomach smaller. And so when you fill the stomach, then it's going to increase the pressure and could lead to reflux. But the hernia has to do with the weak diaphragm muscle. But being obese in general can cause a weak diaphragm muscle. Hernias, no matter where they are, like a inguinal hernia, which we'll talk about next week, is just a weakness in the muscle. And that area of weakness causes an organ to protrude through.
So like a parent, like a woman who's giving birth to multiple children?
Right. So that a woman giving birth to multiple children, that more puts them at risk a lot of times for like they get all kinds of hernias. I'm not even gonna lie, but umbilical hernias or epigastric hernia. But yeah, things like that. That pressure is now pushing the whole structure of the stomach up. So pregnancy, yes, probably, definitely could put you, repeated pregnancy could put you at risk. Does that make sense? Because it's like the whole stomach is being pushed up. So a gastric bypass, it's just cutting off a part of the stomach or, sealing that part off, making it smaller. But it's not necessarily weakening the diaphragm. We good there?
Yep.
Okay. Again, it's probably not, if there's hiatal hernia on your exam, it may just be 2 questions or something. It's not going to be something huge. It's a lot of people walk around every day with a hiatal hernia. It's not something that someone's even going to be in the hospital for unless they're getting that surgery. And I'm guessing likely if they get that surgery, it's probably like 24-hour observation and go home, or even go home that day if it was laparoscopic. So I've never taken care of someone in acute care for a hiatal hernia. Okay. So but I just want you to understand what it is, because you will see it a lot. You'll see it when people go get CAT scans. You'll see it a lot. And I also wanted you to know, the diaphragm, how it relates to GI, but it also relates to respiratory. So respiratory dysfunction is gonna cause issues to the GI. It's also gonna cause issues to the heart. So I want you to be able, by the end of this class, to relate everything to each other, if that makes sense. But for right now, we're just talking about GI. Anatomy and physiology of the stomach and duodenum. Now, the stomach serves as a reservoir, right? It's just a little holding place for food once it comes down the esophagus. So it's gonna travel from the esophagus through that lower esophageal sphincter into the stomach. The stomach is then making and secreting gastric acid to break that food further down into, you see this word in the bottom paragraph, chyme, CHYME. That is what that food breaks down into once it passes through the stomach, okay? So it comes down after you've chewed it up and the mucus slid on down the esophagus into the stomach. The gastric cells are protected with a lipid barrier. That lipid barrier and the stomach lining are supposed to be impermeable, meaning acid shouldn't be able to get out of the stomach, shouldn't be able to eat its way through the lining, usually. But certain things are going to either cause excessive gastric acid production, or they're going to weaken the lining, or disrupt that lipid soluble, that lipid barrier. So things like NSAIDs, aspirin, alcohol, those things are going to weaken the lining and the lipid barrier of gastric cells, therefore putting you at risk for PUD, peptic ulcers, peptic ulcer disease, gastritis, irritation, inflammation in the stomach, right? We talked about prostaglandins before. Prostaglandins work to carry the message to the brain about pain. They carry that message across the nerves. They also work to decrease acid secretion and increase bicarb production. And that has to do again with that fight or flight. When your body is in fight or flight mode, when it's in shock, it is going to put all its energy into preserving the vital organs, like your heart, your kidneys, your brain, your GI, not so much. So we'll talk about that more later on with cardiovascular stuff. But so when you're in that fight or flight mode and prostaglandins, those chemicals are being released, they're going to slow down the acid secretion. Remember, rest and digest. Fight or flight. You're not going to be about ready to fight talking about you're hungry, right? You're not going to be thinking about being hungry if you're getting ready to fight. So when you use drugs like NSAIDs, which inhibit prostaglandin production, which we talked about with inflammation. That is another reason why NSAIDs are going to put you at risk for ulcers and gastritis. Everybody get that? So not only do they cause irritation and break through that barrier, but NSAIDs also inhibit prostaglandin production, therefore increasing acid secretion and decreasing bicarb production. Bicarb is a buffer, and we will talk about that when we talk about acid base. The duodenum.
Okay.
Yeah, somebody had a
Sorry.
question? I'm sorry.
So basically, when you take the NSAIDs, you're putting yourself more at risk.
Yes. NSAIDs are going to put you at risk or even be the cause of gastritis or peptic ulcers. You can eat a hole through your stomach taking excessive ibuprofen or aspirin. So NSAIDs, because it's a double whammy, they inhibit the inhibition of the prostaglandins is going to decrease bicarb production and decrease. So that's why, remember before, and I probably said this wrong, but it wasn't on your exam, but NSAIDs, when I said, if you give someone, say something causes GI upset, certain pills make you nauseous. If you give it IV, it will bypass that GI tract and lower your risk of being nauseous. So if you don't give the NSAID orally and you give it IV, while it may not disrupt or irritate the lining of the stomach, and it may not do anything to this lipid barrier in the third bullet point, it will still be inhibiting prostaglandin production, still putting you at some risk with increased acid secretion and decreased bicarb production. Remember, the body has a way of balancing itself out, right? Just like the inflammatory process cannot go on and on forever, or else you're going to end up with an inflammatory or autoimmune disorder, right? So same with, homeostasis, keeping that balance, that equilibrium, all right? Keeping the vibe right, all right? Everything needs to be even, moderate, chill, okay? As your body produces acid for digestion and acid, to protect your body, it also needs to know when to calm down, okay, before you burn a hole through your stomach. So your body is also at the same time producing sodium bicarbonate, which we will talk about when we talk about acid base. But again, all these things are related. So that's why you're going to see, I'm going to keep coming back to inflammation. I'm going to keep coming back to immunity. I'm going to keep repeating myself throughout the entire semester because the entire body works together. So if we go system by system and you piece it together, I just feel like that is so much easier than trying to worry about inflammation in the lungs and the vagina and the intestine. It's just too much. Okay, no, it makes no sense. Okay, so the duodenum. The duodenum it got cut off here, but if you see my arrow, it's right here. So you have your esophagus, you have your LES, the lower esophageal sphincter, that valve that lets the food pass from esophagus to stomach. You have the stomach. The top part of the stomach is called the fundus, and rugae are just the little folds in the tissue. Okay, this is just a recap of A&P. But anyway, this is the whole stomach. That is the reservoir, right, where the gastric acid is being produced now. And then at the end, the tail end of the stomach, you have the pylorus region, okay? And we'll talk about that in a second. And then from there, where the pyloric sphincter opens up at the end of the stomach, so you got a sphincter for the opening here and a sphincter at the end, just like the esophagus has an upper esophageal sphincter and a lower esophageal sphincter. that sphincter is going to open up, and then you're going to be at the duodenum, which is the first part of the small intestine. Okay. This is where bile comes into play. Bile is created and processed with the pancreas and the gallbladder. It's going to pass through the bile duct, and it's going to be dumped off into the duodenum, so the duodenum can take that chyme, that food that's been broken down with gastric acid, and then further break it down more with some bile. Okay. Yeah, and then the duodenum, from there it goes to the jejunum. You may see you will see this in the future, G tube versus a J tube. There is a difference. A G tube is in the gastric region. It is a feeding tube in this gastric region. A J tube is going to the jejunum, which is essentially part of the small intestines where nutrients are absorbed. Therefore, the diet for someone with a J tube, and there are different precautions with a J tube versus a G tube. And we'll talk about that next week, okay? So let's talk about disorders of the stomach and duodenum, right? Gastritis. Anything itis just means inflammation, right? So gastritis is just inflammation of the stomach lining, the gastric mucosa. It could be acute or it could be chronic, all right? It's usually associated with the use of irritants, aspirin and NSAIDs, like we talked about, gonna put you at risk for gastritis. Bacterial toxins, H. pylori especially, but again, you can get gastroenteritis, gastritis from eating something bad with other different bacterial toxins. So hence why certain food, might have like a certain E. coli in it, and it's releasing toxins that cause inflammation of the gastric lining and cause you to vomit to try to get that out of your system. Once that toxin is removed from the equation, the gastritis typically resolves if it is acute, right? Alcohol can cause acute or chronic gastritis, right? Symptoms are going to be upper abdominal pain, epigastric pain, upper middle abdominal pain. You may have vomiting if it's related to like food poisoning. You may have hematemesis, which is bloody vomit, blood in vomit. It could be blood tinged, or it could be coffee grounds, or it could be like gross, frank blood. And we'll talk about that in a second. Treatment is usually self-limiting in nature. You could treat it with the same meds we already talked about, PPI, H2 blockers, and antacids. Same information about the meds for GERD, same information about the meds here. All right? Usually resolves once the irritant is removed. Like I said, if you've been on a drinking binge of alcohol, and then you stop drinking, take some antacids, adjust your diet, that gastritis could resolve. Versus if you're like a 20-year alcoholic, you've probably already destroyed your gastric lining. You've put yourself, again, chronic inflammation, chronic irritation is always going to put you at risk for cancer. So stomach cancer is directly linked to excessive alcohol abuse and other things that cause chronic gastritis. Again, I'm just trying to put this in your head so everything makes sense. Why we do the things we do. Why we don't want acute gastritis to get to chronic gastritis. Chronic gastritis basically is going to lead to peptic ulcer disease. It's going to cause erosion of the mucosal lining of the stomach. It can affect the esophagus or the duodenum, okay? So any of those areas. So GERD can lead to peptic ulcers in the esophagus. Any of these gastritis issues we just talked about can lead to peptic ulcer disease. And then if that ulcer occurs, the most common area is the duodenum. Why? Because bile is even more acidic. And when bile has the ability to back up into the stomach, that is really going to put you at risk for gastritis and ulcers in the stomach. Can put you at risk for scarring of your pyloric sphincter, okay? So bile is very acidic, and therefore these ulcers most often occur in the duodenum because that's where the bile is going, okay? You don't have bile in your stomach. You shouldn't have bile in your stomach, okay? Causes, most common cause of peptic ulcer disease is H. pylori infection. H. pylori is a bacteria. It's not really clear on how people get it because it could be foodborne, it could be person to person, it could be fecal oral. They have all these speculations, but all you need to know is it's a bacteria that releases toxins that has the propensity to cause chronic gastritis and lead to peptic ulcers. So typically anybody getting an EGD, no matter what the case may be, is going to get an H. pylori biopsy or test tissue sample taken just because it's so common. It affects a lot of adults, okay? Other causes, again, NSAIDs, corticosteroids, okay? Severe stress, whether it's you've been burned up all over your body, critically ill, sepsis, you're hospitalized with some acute illness, severe stress is going to increase the release of gastric acid, and it's going to put you at risk for peptic ulcers, okay? Hypersecretory states, anytime you have excessive gastric acid being secreted, is going to increase your risk. Family tendency, if you have a tumor on the gallbladder or pancreas and that's affecting your production of bile, that's going to increase your risk for a duodenal ulcer. Excessive alcohol, we already talked about that. Risk factors, we've already talked about that. Same risk factors as GERD and gastritis, okay? Again, that's why I feel these chapters, and this next exam is going to be so much easier for you guys because they're all about the same. You know, you only got to remember so much. We're only talking about GI. Clinical manifestations. So someone has peptic ulcer disease, they're going to complain of heartburn, bloating, nausea, maybe vomiting, but probably not, unless maybe they're having like bleeding ulcer. But they may perceive as uncomfortable fullness or hunger. I want you to look at that table right there. I got it straight out of ATI, okay? The difference between a gastric stomach ulcer is the pain is exacerbated by eating. When you eat, it hurts. Versus a duodenal ulcer, pain is relieved with eating. When your stomach is empty, it hurts more. Okay? Because the duodenal ulcer is in the small intestine, you're going to have melena or blood in your stool. And we'll talk more about melena next week. And because the gastric ulcer is in your stomach, you're going to have hematemesis. Okay? So become familiar with those differences. You're going to have weight loss if they're refusing to eat with the gastric ulcer. Weight loss in, if a baby you know, God willing, has or a small child has a peptic ulcer, then they're probably going to have weight loss. They're going to refuse to eat. Pain with palpation in the epigastric region. And then again, the hematemesis and the melena. Oh shoot, we'll go to that next. All right. Okay, for some reason, this video, I gotta play it in a different screen for you. H. pylori testing. Again, like I said, it could be done during, this is an EGD procedure you're about to watch. It could be done during an upper GI study. When they go in with the camera, they'll take some tissue and send it to the lab for sampling, test for cancer, test for H. pylori. They always do that with the EGD. Unless, you know, unless the patient was recently tested or this is an emergency. But if it's scheduled, an EGD, almost every GI doctor is going to test for H. pylori. The other way you could test for H. pylori is through the stool or through the urea breath test. Okay, all these tests are not going to show you the H. pylori testing. It's not going to tell you the patient has an ulcer, but it could lead you to why they have the ulcer and then help you treat the ulcer. The EGD is going to be the only thing that's going to actually visualize, okay, hey, this person has an ulcer. The H&H, hemoglobin and hematocrit, those are your red blood cell counts. They are a component in the CBC. We talked about CBCs last week. So you could either, a doctor may just order specifically an H&H, or they could order a whole CBC. Either way, you're going to be looking at the H&H to see, is it dropping? Are they bleeding? You may test their stool for melena or occult blood in the stool, microscopic blood. So let me, hold up, wait a minute. Let me, I want you to see this video. Does anyone have any questions right now about anything at all? No? Wonderful. Beautiful. Let's see what's wrong with this stuff. We can. Hold up. Let me see. Seriously? Hold on. First of all, I don't know who Elizabeth Ann is. I took this laptop from the school. Don't judge me. Is it this one? Just a moment. Oh, it's not that one. All right. It is. One more second. Did I download it? This one? All right, it's this one. Sorry about that. This was a different, I don't think any of you guys in here were with me last semester, so don't worry. So everybody go on mute. I really just want you to see this procedure. It's only 5 minutes, but I want you to see because it really, like, you can visualize everything we just talked about with the EGD. The patient's lying on the left side, how they're positioned. You see them getting the conscious sedation, and the doctor is talking you through the whole process. If every single person is on mute, you should be able to hear the video. So let me open. Can you see the video right now for the EGD?
Yeah.
Okay, cool. All right, everybody mute. Make sure everybody's on mute. Shoot. All right, everybody's on mute. Good. All right.
We're getting ready to do an endoscopy procedure on this gentleman who's got a GI bleed. Apparently, he's known to have marked ulcers, and we will see if that's actually led to any bleeding. So, the patient has given me permission, as long as it's facing the mask, to do this video. So he was scoped about 2 weeks ago, and what did you find at that time? It was an old, okay, a large one? Okay, all right. And so it looks like that thing's bleeding now. What's bleeding? Okay. Okay. Good, take a deep breath. Can you tell me where we're at? Now, this looks like the stomach. Okay, okay, you're good to go. Okay. What is that stuff, food? So that's the clip from the prior procedure, okay? So our oxygen's hanging in there good. Patient's tolerating the procedure well. Okay, second part, duodenum. What you can see with those scopes are just phenomenal. That's just so impressive. The blood is actually just from the natural trauma that you get during a sedation, the natural trauma that you get during a procedure here. He's oxygenating fine, entitled CO2 is fine. Getting a little bit more Versed and fentanyl. Blood pressure's hanging up there good. Now, are you seeing anything on this at all?
Well, there is this mass-like protrusion down here that you see.
Mass-like protrusion.
Might be a directed viaduct or something like that. You need a side view scope.
Okay. So side viewing scope needed. Check out a mass.
Okay. Everybody saw the video. You could hear it decently. Oh, well, did everybody else see it besides Aaliyah? Anybody?
Yeah, we saw. I
It was
saw it.
lagging
It was
bad,
good.
but
It
you could
was
see it
lagging? I don't know why it does
at the
that.
beginning.
Oh,
I
well,
was hoping to see more.
you couldn't see, you wanted to see more.
Yeah, like I was hoping that we would be able to see ulcer or something.
Oh, well, I could send you some videos if you really want to see an ulcer. The thing I wanted to show you really was, for one, you're not going to be doing this procedure, so you don't need to worry about how to identify an ulcer in someone's stomach. That is a doctor's job, not only any doctor, a specially trained doctor. As you could hear that ER doctor saying, what is that? Is that food? I don't know. Why? Because he doesn't do EGDs every day. So I can show you some videos if you want to see an ulcer just to see what it looks like, but it's not information you necessarily need to know, if you get what I'm saying. You do need to know how to prepare a patient for the procedure, such as lay them on their left-hand side, administer conscious sedation, monitor them after administering drugs with conscious sedation, knowing that their throat is going to be sore after the procedure, those kind of things. But as far as like, I just don't, I know like you want to see stuff, that's cool, but, and I will show you, I don't have a problem because I like seeing weird stuff too. But as far as what you need to know right now is what does this mean for me as a nurse? So I was just trying to just show you the procedure. But I'll find you something good with some ulcers so you can
No
look.
worries. I'll be on YouTube tonight, sir.
Oh, there you go. Actually, and to be honest, it's better too when you work in the hospital, because when your patient goes down for an EGD, they're going to come back with pictures. It'll be like screenshots. The doctor, because I think honestly, unless you're a GI doctor, it's going to be hard to watch a video and identify an ulcer unless it's like spurting out blood or something. Like this takes a specially trained eye to be a gastroenterologist and to do these procedures. That means they did a fellowship. Their studies were based in GI. So not every doctor in the world, I wouldn't ask my gynecologist to identify a duodenal ulcer on an endoscopy, or my primary care physician. But I'll certainly, go ahead, get on YouTube, girl, YouTube it up. I just don't want you guys to get hung up on stuff that you won't need to know, and then forget about the stuff you really need to know. What the heck? I'm trying to get out of this screen. Hold on. All right, sheesh. All right, let me go back to my other PowerPoint. Sorry about that. All right, so anywho, where were we? We're almost done. Just a couple more things and then we'll be done. So upper GI bleeding, right? You're gonna have people who always say, oh my God, I'm spitting up blood. Oh my God, my baby's coughing up blood. Now, there's a difference between blood tinge and straight up like hemorrhage or coffee ground emesis. This top picture is indicative that is a picture of what we call coffee ground emesis. It may be somewhat lighter, it may be darker, whatever, but when you see this brown coffee ground like substance, that should alert you, oh shoot, this patient is having a GI bleed. You're not gonna tell them, oh, eat more. Why? Because they're having a bleed. You're going to call the doctor, or if you're in the ER, you're going to notify a physician, hey, come check this out. I think the patient's having coffee ground emesis. Can it be mistaken? Sometimes, yes. I've had, I've thought something was coffee ground emesis and it wasn't. People eat and drink certain stuff, you may think something's blood tinged and maybe the patient just ate a red popsicle. So stuff happens, but for the most part, you'll be able to identify coffee ground emesis. So that is going to be a sign of a GI bleed. This little spot of blood right here, or if somebody coughs and it's just a little bleeding, yeah, that's just from irritation, whether it's GERD, like with the babies, when they said they may have some blood in their vomit, it may be like that from just light irritation. If you've been vomiting excessively, and you know, say like a person, I don't know, you have some GI disorder or infection or a hangover or whatever, and you're vomiting excessively, you may cause some irritation and minor tears to your esophagus. That is a little blood tinged sputum there, or blood tinged vomit. That is not the same as coffee grounds. That is not the same as hemoptysis. That is not the same. Hemoptysis is coughing up blood. And that's not the same as esophageal varices rupturing. When esophageal varices rupture, it's going to look like either coffee ground emesis or frank red blood, okay? So I just want people to be aware of that, because you hear it, people say it all the time. Oh my God, I was coughing up blood. I was choking up blood. My baby spit up blood. Okay, yes. I mean, technically they're right. It's a little bit of blood, but it's nothing to be alarmed about. And it's likely just due to irritation and will go away. You know, remove the irritant, take an antacid, soothe your throat, you'll be fine. Now, treatment. Again, if it's related to H. pylori, which a lot of times it is, then they're going to need antibiotics. Because H. pylori is kind of a chronic infection. It's a tricky infection. It requires being they usually do 2 antibiotics, unless it's some real severe infection, maybe they'll do 3, but usually it's 2 antibiotics and then either a PPI or a H2 blocker. So if the peptic ulcer is caused by H. pylori, then antibiotics will be part of the treatment, 2 to 3 meds at a time. And these are the antibiotics they typically use. It will depend, you know, if the patient has allergies, what have you, what other meds they're on, but these are typical antibiotics that they will choose. And then a PPI or H2 blocker, we already talked about those. They may be used in conjunction with antibiotics for H. pylori. You will also see when you go to clinical, if any of you go to the hospital, or if you maybe work in a nursing home even, you may see patients all prescribed PPI or an H2 receptor blocker for GI protection. Because remember that chronic disease, acute illness, excessive stress can increase risk for these ulcers. The H2, I already told you, is twice a day. PPI is usually taken first thing in the morning prior to your first meal, okay? Mucosal protectants. This is a new one. We didn't talk about this one. Those include sucralfate, or Carafate is the brand name for it, easier to say, and Bismuth, which is like Pepto-Bismol. Mucosal protectants are going to actually coat the lining and allow the ulcer to heal underneath it. So, you know, you'll hear people say like, oh, you think like H2 blocker or PPI, those work to decrease secretion of acid. Antacids work to neutralize acid, and mucosal protectants coat the lining and allow healing underneath them. So that's why those are really reserved for like people who have ulcers usually, or real bad gastritis and inflammation. Lifestyle modifications, again, same lifestyle modifications for all upper GI disorders. Complications. So the reason they were doing that impromptu EGD at the bedside there, the patient had a low hemoglobin and they were worried about a GI bleed, okay? So that probably, and to be honest, something like that being done in ER, like you heard the doctor, oh, is that food? I don't know. They may not have even been able to identify, necessarily, unless it was some huge, outrageous ulcer. But the reason we're going to be concerned about that, the reason we're going to call the doctor when we see coffee ground emesis is because an ulcer can essentially lead to a hole or a perforation. It can eat right through your duodenum, right through your stomach, right through your esophagus. What it can lead to then is hemorrhage, obviously, with the coffee ground emesis, or melena, dark, black, tarry stools. Those are signs of hemorrhage. Another thing is severe life and death infection, peritonitis. So if your small bowel is perforated and now it's just leaking all this waste product into your peritoneal cavity, your abdominal cavity, you're going to be at risk for infection and probable death. It is a surgical emergency. If somebody comes into the ER with a perforation, if a patient, for example, I had a patient one time working med surg who had a colonoscopy. Luckily, thank the Lord, I had the patient a couple days in a row, so I knew him. So the one day I came in to see him, he was confused. He was disoriented. He wasn't making any sense. He was also diaphoretic, dripping with sweat, and his temperature was 104. The nurse who had him told me, oh, yeah, he has a fever. He's just confused, He was old. He was older. So, she didn't know him. She attributed him. She gave me a report and told me the patient's alert and oriented ×1, meaning alert and oriented to self, meaning what the heck happened to this guy? Because yesterday we were talking about all types of stuff, sports and everything. So again, this is nursing. But what had happened was the patient was there for, I forget what it was, but it was a bowel issue. He had a colonoscopy, and during that colonoscopy, they perforated the bowel, poked a hole in the bowel. So now you got all this waste product leaking out into the stomach. The abdomen's going to be rigid. It's going to be tender, and they're going to have a high fever. That is a life and death emergency. A person will die quickly. But I'm not like patting myself on the back. These things happen in everybody's career. It's just an example of how quickly a patient could get sick. And also an example of, you really need to know your patient. If you've had this person a couple days in a row, it's going to give you an advantage over somebody not knowing the patient. And also, hence why report is so important. If I didn't know the guy and you're just telling me he's always confused, I may think, maybe he has a UTI or something. I might not be thinking, oh my God, let's scan his belly. And sure enough, they found a hole. What was that hole caused by? Actually by the doctor doing the endoscopy or the colonoscopy. And the patient did require emergency surgery. So perforation is a serious complication, life-threatening complication. Hemorrhage, again, depending on the amount that you're bleeding, if you have a perforation or a huge bleeding ulcer, again, that can be life-threatening. A person can die quickly. I've seen young people come into the ER with a GI bleed and die in the ER, come in walking, talking, and die within an hour due to GI bleed. This is serious. And then scarring, because of the excessive irritation and inflammation, you can start to have scarring in that pyloric area, leading to gastric outlet obstruction. So now the food can't travel from the stomach to the intestines. So no matter what the case, if you have a perforation, a hemorrhage, or any of those, you're going to probably need a gastrectomy. That's going to be partial surgical removal of the stomach, may even involve the duodenum. The client, obviously, if you're removing part of the stomach or part of the small bowel, is going to be at increased risk for malabsorption issues, vitamin deficiencies. So those patients need to consume small meals. And this goes for that bypass surgery you were asking about, Joe. When people get that bypass surgery, it's the same. They have a lot of issues with digestion, malnourishment, and vitamin B12, pernicious anemia due to vitamin B12 deficiency. So whenever you remove part of the GI tract, you're going to increase risk for all type of malnourishment issues. You're going to encourage them to eat small meals. And complications include dumping syndrome and, again, malnutrition. Like I said before, I can't like read the entire book to you, but I'm trying to give you the most I can give you without talking you hopefully all the way to death. So more information on these complications. If I put a page number in there, you need to go back and read them. Okay. Now how the heck, what's going on? I got stuck. I'm almost done. If I can change the slide. Anybody have questions? All right, last disorder that we're going to talk about tonight is going to be pyloric stenosis. Pyloric stenosis is a pediatric issue. It causes obstruction. That's different. Now, you could have stenosis caused by scarring, but the condition pyloric stenosis is referring to the pediatric condition which occurs in the first weeks of life. Just like you have the LES up here at the beginning of the stomach, you have your pyloric sphincter, here. And as you can see, that hypertrophy or that stenosis, that stiffening, hardening, it's usually like a birth defect, and it needs to be corrected with surgery. And the only risk factor is genetic predisposition. Yes, they have projectile vomiting. That's why I put this here with the projectile vomiting in the picture. Usually occurs in the first weeks of life. They're going to have the projectile vomiting. Now, remember, the bile is down here in the duodenum. If this is locked down, walled up, this is going to be non-bilious vomitus, okay? The vomit is not going to have bile in it, okay? Also, they may have some blood tinge from the irritation from all the projectile vomiting. Blood tinged, not coffee ground, okay? They're going to be constantly hungry because they can't do anything. Every time they eat, they have projectile vomiting. They may possibly have an olive-shaped mass because those babies are just so small. You may even be able to see a little lump up under the xiphoid process in the upper abdomen area. They are going to have failure to gain weight, failure to thrive, dehydration. Obviously, dehydration is detrimental to an infant's health. If they're not able to drink, they are not going to survive very long. So it may not be a, it's not a surgical emergency as if they're going to die right this moment. So if a patient comes in, we find, and the mom brings a baby in, 2-week-old baby, and they're having this projectile vomiting, and they do the ultrasound and they find pyloric stenosis, does that patient need to be whisked emergently to surgery? No. If they have a perforation, yes, we're running the surgery. Whether it's 2 o'clock in the morning or whatever, you're calling a surgeon at home, you're telling them bring their butt to work because we have an emergency on our hands. Projectile vomiting with the baby, we can give them IV fluids and monitor them and get them to surgery tomorrow. So while it is a surgery definitely required, it doesn't need to be emergent like the perforation of the stomach or the bowel. This is the surgery, pyloromyotomy. Anyway, just like other surgeries, you're not going to need to know like this specific surgery. You're not going to need to know that for NCLEX. You're not going to need to know the nitty gritty details of this specific surgery. All you need to know is one, that patient needs IV support because they have no other way of obtaining nutrition. Two, you're going to monitor for dehydration, electrolyte imbalance, daily weights. Baby's weight is how you tell. That is the easiest way, the most accurate way to tell if an infant is dehydrated. Daily weights, okay? Monitoring I's and O's. And then for the surgery, you just need to know they're going to be NPO before the surgery. And after surgery, they're going to get clear liquids and advance as tolerated. That's it. That's all. But again, you don't need to know the ins and outs of how to perform a pyloromyotomy, okay? But you can YouTube it if you wish. That's all I got for upper GI for now.